We're switching gears a bit right now. We're moving from an MPH student to a faculty member in the department, Dr. Ann Wyllie, and she is right there in the thick of the COVID-19 research that's going on in our department. So we're very lucky that she gave us her time to talk about some of the work she's doing. And before you start, I just want to point out that I noticed today that you're the lead author on this multi-author study that is coming out about the preferable, that the saliva samples are preferable to the deep nasal swabs as far as diagnosing COVID. And you can read about this on the Yale News, and I'm sure it's going to make big waves in the field. And congratulations on that. With that, I turn it over to you.
Thanks, Brian. So actually, along those lines, that's exactly what I'm actually going to end up presenting on today, is the work that's gone into that publication that's come out. This is, however, an updated version of this. We've gone back into the data. This is obviously a massive ongoing study that we're doing. So since the publication of the preprint, we've gone into it and we've expanded the data set. So I'm going to continue presenting on those results today. So indeed, we've, through the work that we've been doing at the Yale Biorepository, we've found saliva to be a viable sample type for SARS-CoV-2 detection in COVID-19 patients. So for upper respiratory tract pathogen detection in general, well, especially now for COVID-19, the CDC is recommending the collecting and testing. They broadly state upper respiratory tract specimens, but then they more specifically state nasopharyngeal swabs. So the nasopharyngeal swab is considered to be a gold standard for upper respiratory tract pathogen detection. However, it is, I don't know if anyone has had one yet, but they are very uncomfortable. They can also lead to irritation, meaning that the patient can end up sneezing or coughing on the healthcare worker who is trying to obtain that sample. There we go. There is also the oropharyngeal swab. This is more tolerable. This has also been mentioned in the CDC recommendations. But from a number of studies that are coming out that are directly comparing the oropharyngeal swabs and the nasopharyngeal swabs, they are proving to be less sensitive for detection. And that's also something that we saw with preliminary testing that we were conducting in the Biorepository here at the School of Public Health as well. Saliva sampling, however, it is quick and easy, and it's considered to be non-invasive. There were previously very few mentions of it in the literature as a potential type for SARS-CoV-2 detection. There was this nice small study published in CID where it was suggested to be a promising potential sample type, where they collected saliva in 12 COVID-19 patients, and they were able to get virus detection in 11 of them, and they presented these nice results. However, there was no direct comparison to this gold standard nasopharyngeal swab, and again, the sample size was quite small. However, in other studies, there has been about over a 90% concordance of saliva compared to nasopharyngeal swabs in detecting respiratory viruses, including other coronaviruses. What's great about saliva is that healthcare workers are not required to collect the saliva samples. This really reduces the risk of nosocomial transmission. It can eliminate waiting time for specimen collection, so results can be available sooner, and this could be really useful in really busy clinical settings where the number of available staff is limited. So this also gives a very practical sample type for efficiently screening a large number of individuals. It's also a sample that can be collected in the absence of airborne infection isolation rooms, which means that can be sort of, widely used just in the outpatient clinic settings or in the community. And could also be a potential for serial viral load monitoring, in that it reduces that discomfort to patients, it reduces that risk to healthcare workers, particularly over repeated sampling moments. So if you were monitoring the viral load over the course of someone's infection. So what we're doing here in the School of Public Health is we're setting up the Yale Biorepository. So for this study, we were looking at the COVID-19 inpatients. So these are hospitalized patients at Yale New Haven Hospital who have tested positive for COVID-19 in in one of many sample types. So whether that was like a nasopharyngeal type sample type, oropharyngeal, sputum, or even urine sample. So participants enrolled into this study had to be over 18 years of age, and we had to get signed informed consent either from themselves or through a surrogate. And for this particular paper, we're looking at the nasopharyngeal swabs and saliva samples that were obtained roughly every 3 days throughout their clinical course. For the saliva sample, this was just, the patients were just simply asked, they were given a collection cup, and we just simply asked to like collect some saliva in it upon waking up first thing in the morning. And this is just an example at the bottom of the study design where the individuals are consented. On day one, we collect this whole range of various samples, which we've been testing for SARS-CoV-2, as well as putting into the Biorepository for future studies, with repeated collections every 3 days or so. We've also been looking at asymptomatic healthcare workers. So these are healthcare workers who are working in Yale New Haven Hospital on COVID-19 wards or have other occupational exposure, so at risk of COVID-19 transmission. So as well as collecting samples, this is to also serve as active screening to help prevent transmission in the workplace. So these healthcare workers are enrolling into our study, and again also sampled around every 3 days. Their sample types, however, apart from some blood draws, are otherwise just a self-administered nasopharyngeal swab and or a saliva sample at each time point. So it's up to them what they collect and what they provide us with. And again, just an overview of sort of the study design with the consenting, the initial blood draws, and then we're going to be following them quite ongoing, just twice weekly screening them for any SARS-CoV-2 detection. So samples are collected and they are all transferred to here on the 6th floor at Albert's lab, where there's a massive undertaking in aliquoting these all. Once the samples are aliquoted, they come through to us for RNA extraction, a couple of pictures of us doing so. And once we have the RNA, we are sending it over to Akiko Awasaki's lab for qPCR detection. So qPCR detection is what is being used for SARS-CoV-2 detection, and we are using the CDC N1 and N2 assays. There are a number of other qPCR assays being used in other areas, so when we started needing to sort of build a response to this and decide sort of which methods we were going to be using for SARS-CoV-2 detection, Chantal and Nate actually acquired some RNA transcripts, virus transcripts, and as well as all the different assays, and spent quite a lot of time testing these on the RNA itself, also in mocked controls and different standard curves, just to make sure that we were going to be using the assays that were sort of most sensitive, most reliable, and just have like a good understanding of getting them up and running quite quickly for reliable use. So we are just using the N1 and N2, which is recommended by the CDC. We also include the RP. This is an RP gene. It's a human control. It's sort of just like more a positive control to sort of indicate how well our sample is, or how well it's, to make sure it's gone through both RNA extraction properly, but also an indicator of how sort of the quality of the sample that was taken in the first place. And that's something that CDC also really highlights on their recommendations, and that this should be included. So we're testing every sample in all 3 of these assays. So far, having expanded our study population and updated it just last week, we are now at 85 inpatients, roughly half are male. We have an age range of 26 to 95 years old, with the average being 64, and you can see on the graph that we do have a lot of patients being in that 60 to 69 year who have enrolled in the study, I should say. And 16% of these were admitted straight into ICU on admission. However, 38% of them ended up in ICU during hospitalisation, with 24% on mechanical ventilation. And as of April 20th, 9% of them had passed away. In our healthcare worker population, where we were, as of last week, up to 178. This is, I think, well over 200, maybe even up near 300 now, after I've just updated a lot of the data from the last few days. Only 16% male, and an age range of 22 to 74 years. And mean age of 36. We've now, or when we last updated the data, we had 515 total samples from those individuals, slightly less saliva samples compared to the nasopharyngeal swabs. To look at specifically at the inpatients though, so so we had the 85 individuals and the 210 total samples, and you can see how they're distributed, but just to really highlight the matching samples that we have. So we have 122 matching samples, or 61 of each sample type, the saliva and the nasopharyngeal swab. And this is actually from, I believe, I want to say 49 patients. What you can already see is looking at these matched samples. So just remember that these samples from the inpatients, these are all COVID-19 positive inpatients already. So these are all patients who have tested previously positive for COVID-19. And you can already see that saliva overall in these matching sample types did a better job at detecting positives as compared to the nasopharyngeal samples. And this is something that we started noticing earlier on in the study, and particularly as we were starting to see shortages due to the supply chain issues with limited nasopharyngeal swabs, limited even 15 ml conical tubes, having to make our own biotransport media for different swabs. You know, as we sort of started coming across these challenges, that's when, you know, we started looking at these results that were also coming in for saliva and sort of keeping an eye on those. And after a while, noticing that we were getting, you know, really good detection as compared to the nasopharyngeal swab. So for that reason, this is why we sort of started paying attention to the saliva results that we were getting, and why we kept sort of looking at them further. So what you can see here is that if we look at the viral load in all the positive samples that we obtained from the nasopharyngeal and saliva samples, there is on average a slightly higher viral load detected in saliva. Looking at all positive samples, this didn't actually reach significance, but it was about sort of, I think about 2 to 3 times higher viral load in saliva samples. When we look at specifically the matched samples, however, so the same nasopharyngeal and saliva sample from the same individual, and we compare those, we get about 4 times higher viral load in the matched saliva sample as compared to the nasopharyngeal swab, and this did reach statistical significance. And what so this graph C on the right, what this shows is it shows the viral load detected in the nasopharyngeal swab as compared to the saliva sample, with each dot representing that same individual. And what you can see is in the top portion of the graph is that these are all samples that tested more strongly positive in their saliva sample than their nasopharyngeal swab. What's also important to see here is that along the bottom in the grey area, these are samples that were positive in the nasopharyngeal swab, but negative by saliva, and that was 7 in total. However, if we look at the y-axis, there are 14 samples that were positive in the saliva samples, but negative in the nasopharyngeal swab. So this actually gives us a false negative rate in these matched samples of 24% in the nasopharyngeal swabs, but only 12% in the saliva samples. We then looked at the viral detection in both the saliva and the nasopharyngeal swabs, plotted as days since symptom onset. And generally what you can see is you can see this sort of nice downward trend in both cases, where as you sort of progress with days since symptom onset, we do see a decrease in viral load. The samples that are joined by the dotted lines are longitudinal samples from the same individual. And what you can really see in these is that while we had one individual who tested negative in their saliva sample sort of around day 11 and then test positive again, we actually had 5 individuals who would test negative in their nasopharyngeal swab, followed by a positive swab later, and then often sort of decreased signal again. So there's not so many lines compared between saliva and nasopharyngeal swabs, but I think it's easy to see that there is quite a bit of sort of almost chaotic sampling in the nasopharyngeal swab, where some are either negative and then positive and then negative again, or sort of high viral load and then dropping off sharply and then coming back up again. We are also looking at the healthcare workers, and so of those who we've enrolled, we have now actually had 8 healthcare workers test positive through our screening system. And this is just to show sort of what we've been seeing. So our first case that we detected as positive, we found them to be positive in their saliva sample. This got them flagged to have the testing through the CLIA lab here at the Yale New Haven Hospital. And actually their nasopharyngeal sample first came back negative. We therefore tested their saliva sample again to really confirm, like this is a new saliva sample taken on the 10th, again came back positive. And then only a few days later from the initial sample did they become positive in their nasopharyngeal sample in the CLIA diagnostic lab. And this is kind of what we've been seeing, is that so far all of our, everyone that we've found positive through our screening has gone on to test positive in the CLIA laboratory, so confirming the results that we're finding here, and just waiting still on the results, the official results from these later two. And just to sort of put these results into context, so these are the viral loads in purple that we're finding in the saliva samples that I've listed. This is just the first top 5 because these are later 2 were newer ones. But you can sort of see they are towards the lower end of detection as compared to the inpatients that we're sampling, so a lower viral load as compared to the inpatients. We are, however, seeing variation in the swab types themselves. So I mentioned at the start how we also test for this human RNase-P gene, which has been recommended to be screened for in all of these testings, as the CDC states, as a quality measure of just how good the sample type is itself. And you can see this, like already looking at just the inpatients, there is more variability in the detection of this human RNase-P. In healthcare workers, however, this did come back as a significant difference in variation. And just to sort of plot what this looks like for some of these individuals, these are their RP values that we're seeing over time. So again, you have instances where this is detecting quite strongly and then coming down and then coming up again. And what just this really highlights to us is that there is variability in how these nasopharyngeal swabs are collected. And this could also have a lot of implications for then the viral loads that we're able to detect from these samples if the sample type themselves is already so variable. This variability is not unique. This is a paper that was recently published in the New England Journal of Medicine, also reporting on nasal swabs. They also looked at throat swabs as well, but in both of them, you can see what we were seeing with our nasopharyngeal samples. Again, you have samples that are positive one day, negative the next, positive the next day, negative again, just sort of this really up and down in, you know, what sort of detection you're able to get from these samples.
Yeah, we're a little close to time beyond.
Cool. And then this is, I think this one and this, just the limitations of the study is that the large number of these are obviously hospitalized, so severe patients. So there is a difference in viral load between mild and severe disease. And so that leads to the question, how is this going to perform in the outpatient setting when we're looking at more asymptomatic individuals or early in illness? There have been a couple of outpatient studies that have just recently come out, and they're also showing comparable results in detection using nasopharyngeal or saliva samples. So just to summarize, I'll just skip straight to that. Saliva is a viable alternative to the MP swab. It's proving to be as good as or even better in early hospitalization and paralleling the performance of the swabs during hospitalization. At the very minimum, it could be considered as an alternative to the time points of nasopharyngeal swabs, just to save on PPE, the swabs required, and also the risk to the healthcare workers. And yeah, that's just the really major one, just the reduced safety concerns and risk to the healthcare workers as compared to the MP swabs. So I would like to finish with saying that this is an incredibly massive team effort. I don't know if this list even captures everyone who's been working on this. We hope it does, but there's of course many more people who are involved in the Biorepository itself, and it's been really inspiring working with such a great supportive team coming together to work on this. And I'm very happy to answer any questions if there's time. I'm sorry.
That was great. Thank you very much. I appreciate, I know, I work right on the same floor. I see you. I know you're working. I think you've basically moved into the School of Public Health. So I know how hard you're working. So thank you for taking the time to give us this talk. If you don't mind, I might skip the question and answer right now because we're running over time. But can I say that people can email you or?
Yeah, they certainly can.
Questions?